So my name is obviously Badre Alam, and what I'm trying to do today is basically try to understand all these drugs we have for the inflammatory bowel disease and how we're going to use it. Fortunately or unfortunately, you can, whatever you can see through it, is basically it's making life really, really complicated for us, but all for the benefits of the patients, and it's also very interesting as well. I have no disclosures. Now, what I'm trying to do, the first thing when we talk about inflammatory bowel disease is most important is to risk stratify the patient. And what I mean by risk stratification is to have an idea what is going to happen to this patient in next few years. We are not talking about how sick that patient is on that particular day, how much diarrhea he's having, how much bleeding he is having. That's all very relatively simpler to manage with steroids and anti-TNF therapy. But where we all fail is to predict the disease course and act properly in the very early phase of the disease. And when we make those decisions, there are clinical factors and non-clinical factors, and I will talk about that a little bit. And then obviously, I'm going to briefly discuss the position of different class of drugs, the older drugs so-called, or the newer drugs in the treatment of inflammatory bowel disease. Now, just a slide, when we plan a treatment, the first thing is to start the most appropriate agent early in the course of the disease. And we have enough data, particularly in Crohn's disease, that it changes the course of disease. How do you define how do you decide which is the most appropriate agent? We'll come to that in a second. This one thing we always fail is this recurrent use of steroid. So please do not wait for steroid to fail 3 times before you change your treatment. There are multiple factors which affect the pharmacokinetics of an agent, and you need to keep that into mind. For example, patient's weight and other factors. Of course, the safety is a big discussion nowadays. Now we have more drugs, so we have the luxury to make a decision based on how safe that treatment is. When we have evidence, when we go through guidelines, they are not crystal ball. Help them to guide your treatment. Just don't follow them or use this drug. They are there to guide you, not to make a decision on your behalf for a particular patient. When you start treatment, always think about that the treatment may need to be escalated, and have that in the mind in the very beginning. And when you make a decision about a first-line agent, also think about what will be my second-line agent if this one fails, and what is the chance of that particular second-line agent working. Now, when we personalize treatment, again, as I mentioned, the first step is to predict the disease course, and I'll come to that in a detail a little bit. Then you target the therapy based on the disease phenotype and the other comorbid conditions. One of the most important things when you treat is to evaluate the disease at intervals recommended, and then basically adjust the treatment, mostly escalation, which can be either increasing the dose or adding another medications, but also sometimes when the patients are doing well, or to de-escalate the treatment. So that's how we personalize. Now, coming to the first point about how do we assess disease severity, and I've summarized them just to make it a bit simpler here. When it comes to Crohn's disease, it's mostly the age of onset, whether they have fistulizing disease, whether they have very extensive disease into the small bowel, colonic disease, whether they have been operated upon earlier, how deep the ulcer is, and if they have obstructed. And that all tells you that this person is going to do very well if I don't treat him is not going to do very well if I do not treat this patient appropriately in the very early course of the disease. Now, when it comes to ulcerative colitis, the outcome you're interested in, can I stop this patient from having a colectomy? And there are predictors which tell you that what's the likelihood of this person getting a colectomy. And obviously, if the patient was young, he had span colitis, he's been hospitalized, has high CRP, low albumin, and if the ulcers are very deep, then I think we are wasting our time with 6 months or 1 year of 5-mesalazine. So you've got to look at these factors very early in the course of the disease, which should guide your treatment choice in the very beginning. Now, when it comes to decision making, obviously the first thing you want to know is the disease effective, and plenty of data to help us how effective the drugs are. What the information which the science is not providing is how effective is one drug compared to another, and that's where we are having problems. So the lack of randomized data in between agents is the problem right now, and as far as scientific literature is concerned. Safety is important. Look, the onset of response is important, but not all the time. Patient wants to get better. We want them to get better, but we're not going to choose a drug just because it makes them feel better quickly if it's not effective long term. So that's one thing to keep in mind. Treatment persistence is important, so you want to choose a drug which is going to work for longer duration of time. So when you make a decision, you need to look at what we call treatment failure rates. So what are the chances of a drug A failing in the beginning, and what's the yearly failure rate compared to drug B? Mode of administration is obviously patient's preference and how your institution is, obviously cost issues. When it comes to patient, apart from what I have discussed, there are other options like comorbidities, age, extraintestinal manifestations. How was the response to previous drug? Have they developed antibody to infliximab? And if that's why they have failed, then you can still use adalimumab, for example. Of course, if the patient wants to become pregnant in near future, and what are the socioeconomic circumstances. So when you see a patient, you've got to sit there, you have assessed the disease, you have done all your mapping, have a diagnosis. But when you're choosing a drug, to keep these things in your mind and have a discussion with the patient before selecting the drug. Now, when we position drug, there is problems. So, we have some evidence. We have long-term, large-scale, real-world evidence in different subpopulations. We have a lot of meta-analysis coming from randomized control trials, although it has its limitations. And then we obviously take extraintestinal manifestations into account. If a particular patient has a contraindication for a certain drug, it makes our life easy. You're not going to get this drug. And we do have scientific limitations. As I said, we do have problems with head-to-head trials. We don't have, real-world data with the newer molecules, which I will discuss. We don't have a lot of data when we start dealing with patients who have refractory proctitis or pouchitis. And like oncology and hematology, we don't have biomarkers to guide us. So yes, we have all this scientific data to help us in deciding which drug to give, but they're not foolproof. There are limitations in that. Now, going back to the drugs, which we obviously want to talk about, I'm going to just focus on what we call advanced therapies. We obviously have anti-TNF, and we are moving to biosimilars. We have a class of drug, which is leukocyte trafficking blockade. What they simply do, they block the lymphocyte from going to the inflammatory sites from different ways. We had interleukin 12 and 23 in the form of ustekinumab, and now we have specific interleukin 23 inhibitors coming very soon. And now we have this very exciting area of JAK inhibitors. And I'm just going to go through them one by one. And I think the purpose here, I know there are a lot of people here are endoscopists and they don't do IBD on a daily basis, and we all get very puzzled and confused with this drug. And the purpose, and I want the focus to be to have an overview that what drugs we have, what do they do, how do I remember their names, and where do I put them and how do I discuss with these patients about how do I discuss when I discuss these drugs with these patients. So anti-TNFs, the question is, are they still the best? We can't answer that question, but they are pretty good drugs. What we do know that they work really fast. When it comes to endoscopic healing, they have the best evidence. No other molecule has been able to touch that scale. We have been using it for many years, so we are very familiar with them. You can sort of write them like paracetamol. And there are certain situations where, like perianal disease, and when one comes to prevention of clinical post-operative recurrence, this is the only drug which have randomized controlled trials. Now, it's probably one of the best drugs we use for acute severe ulcerative colitis. We have excellent data when it comes to infliximab, We have excellent safety data in pregnancy. They're a very effective drug in multiple extraintestinal manifestations. I'm not going to go into details of that, but I just want to give an overview about, let's not just say, oh, the era of anti-TNF is gone. It's still a very, very effective drug. It's a cheap drug, and it works really well again. Now, there are problems, as we already know. Patients make antibodies. We can sometimes to these drugs, and that's one of the major reasons of what we call secondary loss of response. So a certain, a third of patient will have primary loss of response, and 5 to 10% will keep losing response during the duration of the treatment, and that's mostly because of immunogenicity. And there are things we can do to prevent them. We can be very proactive in their drug level, use the drug level to escalate the dose. an addition of immunomodulators. Of course, there is problem with addition of immunomodulators with their side effects, and that needs to be kept in mind when we make that decision. Because there is loss of response, the treatment persistent rate is low. Patients drop out of infliximab for a variety of reasons, because they're either developing side effects or they're losing response, and safety concerns are there for the patients, and as a physician it's our job to basically assure them that these are effective drugs and they work really well in certain circumstances. Moving to the newer drugs, of course, we have the cellular trafficking blockade, and I have subdivided into two groups, which is the anti-integrin, which we have been using for some time, called vedolizumab, both for Crohn's and ulcerative colitis, and the newer class of S1P receptor modulators, which is what we do have, is ozanimod. I personally don't have any experience, but I can with using this drug. But these are the drugs which sort of block the lymphocytes from migrating from one place to another into the colon or into the colon or small bowel. Now, the beauty of vedolizumab is that this is very, very safe. If you look at all the data, it has the best safety profile. Now we have subcut available, so that's one advantage now. Obviously, the immunogenicity rate is very low, so we don't have to use immunomodulator. The dose response curve is not as established as anti-TNF therapy. So we don't have enough data to tell us that if you escalate the dose that we translate into clinical benefit. Saying that, that's not our clinical practice. We do escalate dose in the very early, and we tend to do it quite early in the course if the patient is not responding, but that's not backed up by very good quality science. There was a paper recently, I think in DDW, by Simon Travis, with a very good randomized trial with more than 100 patients and very effective in refractory pouchitis. So that's an area to watch because it may have a role in treatment of pouchitis. The problem with vedolizumab is as a second-line agent, and not only in Crohn's disease, but also in ulcerative colitis, it's actually quite poor response rate if you use it as a second-line agent, and that's a concern. So when you're, as I mentioned earlier, when you're making a decision of treating a patient early, and when you're thinking about what dose, what medication I'm going to give this person if he fails the first-line agent, so I think vedolizumab may not be your choice if you're giving anti-TNF in the very first place. Ozanimod, again, it's a newer drug. The benefit is a single daily dosing, approved for moderate to severe colitis. And I mean, the standard question is, where do I position that? And I think where we will put this drug, if you have mild to moderate sort of ulcerative colitis, you have tried 5 assays, patient is compliant, they're not responding. And I think that will be the place where this drug will sit in. Obviously, if you have concomitant multiple sclerosis, that's a preferred drug because that's what it has been used for before. And there are some indirect analysis coming that it has a comparable efficacy to adalimumab and vedolizumab in anti-TNF patients. So pretty good drug. And there is there was a recent series as well where patient has been, one of the issues we always face when we use cyclosporine for acute severe colitis, what I'm going to bridge this patient with long term. Vedolizumab has been used in the past, but there are case reports when people have used cyclosporine for acute severe colitis, and then I have moved on to ozanimod later on. There are multiple safety concerns which I have sort of summarized there. The summary is, if you have cardiac problem, if you have any problems with eye, you don't go on this drug unless you are cleared by the cardiologist or the ophthalmologist. And what they have used, they use this 7-day escalation dose. So they give you 0.23 and 0.46 and 0.92 in the beginning, and sort of there is some evidence that it mitigates the side effects. In the interest of time, just keep going on. Ustekinumab obviously has been used for severe ulcerative colitis, sorry for that mistake there, Crohn's disease and psoriasis. The benefit of this drug, the best thing is we have long-term data about the durability and the safety. So now we have 4-year data of ulcerative colitis for more than 5 years in Crohn's disease, that the secondary loss of response with ustekinumab is very, very low. So if the patient has responded at week 52, they're very likely to remain on the drug steroid-free in year 3 or year 5. Again, you don't need immunomodulators, and they're very effective in certain extraintestinal manifestations. So these are the stuff you think about when you're using this particular drug. And I'm just going to briefly mention this, and this is probably not very clear, but So the first slide is from a network meta-analysis which are very nicely published early this year, and this is basically looking at a mix of the patient. And if you look at the efficacy of the drug, obviously the upadacitinib and infliximab and the tofa, they sit very much in the front. But the second slide is probably more relevant, is that when you look at the patient who have been exposed to anti-TNF, it looks like the ustekinumab and tofacitinib should be your treatment of choice in patients with ulcerative colitis. Now, when it comes to patients who are anti-TNF exposed in Crohn's disease, and I'm again not going to go into these details of the paper, but this was both our meta-analysis, the risankizumab and ustekinumab tends to stand out as a better drug when it comes to Crohn's disease, and similar sort of translation when it happens in the second meta-analysis. And it looks like that the ustekinumab and vedolizumab, they do very similarly in the very beginning, but the chances of long-term response in patients with Crohn's disease who have been exposed to anti-TNF is better with ustekinumab. Coming back to the newer class of drug, I'm not going to talk about all of them. I'm just going to focus on the first drug because that's going to be available very soon. And it has been proven in obviously randomized trials to be superior to placebo in both induction and maintenance. Very low rate of side effects. The first 3 injections are IV, and then you go on subcut. And where to use, and I think that the place for this will be in moderate to severe Crohn's disease, also in patients who have not responded or has failed prior anti-TNF or other biologics. Should we use it before anti-TNF therapy, or can we use it after or instead of ustekinumab? I think that at least the answer for the last question is still pending. I just want to basically show that if you look at the population which were recruited, what stands out is the number of people who have failed anti-TNF therapy. So what's happening with the recruitment of biologic or IBD medications now? By default, they are forced to recruit more patients who have failed anti-TNF therapy because the options for naive patients are quite a few. And that helps us in a way that at least we know whether these drugs are going to work on the difficult patients or not, because that's where the gap is. So by default, they end up having a lot of patients who have been exposed to either one or actually even more than one biologic therapy. And if you look at the data, if you look at the delta, quite significant difference, even in naive and biofailure patients. The second, the motivate, if you can look at the biofailure patients, the gap is quite good actually. And again, and that response is maintained in the Fortify trial, which actually looks at the long-term response. So very good results, but the most interesting is good results when it comes to anti-TNF therapy. Nothing is perfect in IBD treatment, but we are certainly getting better molecules, hopefully. Just changing gears to the JAK inhibitors, which is the last class, and I'm going to focus on tofa and upadacitinib. I'm not going to discuss about, but the trials are coming up, which will most likely get upadacitinib approved for Crohn's colitis as well. The filgotinib is approved for ulcerative colitis in European Union. Just briefly about tofa, it's what we call a non-selective JAK inhibitors, was basically approved based on Octave 1 and Octave 2 and then Octave Sustain trial. Now we have like 7-8 years data on the safety and efficacy of this drug. Basically recommended by FDA to be positioned only if you have failed anti-TNF therapy, mainly because of safety concerns, which I have summarized on the side. And the main safety concern is the cardiovascular adverse effect, and that data is coming from rheumatoid arthritis patient. Herpes zoster is an issue which probably would have stopped us from using it. The inactivated vaccine, at least in our hospital, is available now, and that's something we should try to get because in your scope of practice, you're more likely to use JAK inhibitors. And in fact, all of your IBD patients, we should be offering them a herpes zoster vaccine because it's a bad disease, painful. Just going back again, there is a role in acute severe colitis as well at a higher dose, just to mention that. So that's one option you can keep in mind. Sorry, I'm not. Okay. UPA is the exciting one because it's available now. It's what we call a selective JAK1 inhibitor. I do want to emphasize here that just because this drug is selective doesn't essentially mean it's more effective, although you will think that this will be more effective and less side effects, but that's not been confirmed yet, obviously. It was approved early this year for moderate to severe colitis, and the network meta-analysis also proves it's quite superiority over other drugs. And as I mentioned, we have good data on Crohn's disease. The dose is around 45 milligram in the beginning for 2 months, and then basically you maintenance dose in 15 milligram, but you can actually use 30 milligram daily if the patient has a refractory severe or extensive disease. And that's the data again. I just want to emphasize the significant proportion of patients who are inadequate responders to biologics, and you can see the delta there again in the, not only in clinical remission, but what's interesting is even in patients who have failed biologic, they have good number of patients actually have endoscopic improvement as well, which is the target obviously we're all trying to achieve. And that's the long-term data in the maintenance trial, and the delta is maintained, obviously. So that's a drug to watch and probably consider now. Now, going back to my last couple of slides, and I'm just repeating what I've said in the earlier, when you have a treatment selection, these are the factors you should consider. And most important is how does the patient understand their disease, and that's where I think we all fail. And that's one of the reasons patients go around to do shopping. Whether women are, what is the patient's age? Are they planning to have children? Have they used biologics? What's the treatment cost? Can my institution provide that treatment or not? What is the treatment? How is the treatment going to affect patients' work? What is patient preference as far as mode of administration is concerned? There's no point giving a drug which the patient is not going to take. And obviously there are factors when it comes to us, which I have summarized there again. And that's one thing, it comes down to my last slide, that the decision should be a shared decision making. We are all used to, when it comes to exchanging information about a disease and a treatment, what we do, we tell patients and patient listens. When we have a very paternalistic approach that I am the boss, then we basically give them only as much information as legally required, like we do our colonoscopy consent forms, But when it comes to, a mutual degree, then obviously, and when it comes to informed consent, we tell patients everything, and the patient makes the decision. It should be neither way. You don't make the decision, they don't make the decision. We should all come to a common ground and then make the decision. And that's what shared decision making is. And I'll give you an example. For example, I have a lady who I've been looking after for 4 years with terminal ileum disease and perianal fistula. I think she's in her mid-20s now. She came to me. I gave her adalimumab in the beginning. She was in a rush. After 4 weeks, she flew to Thailand and they gave her ustekinumab. She's been doing clinically, reasonably well for the last 3-4 years. Never in endoscopic remission, but no steroid, no hospitalization. She wanted to she got married, had an IVF, had a miscarriage. She wants to have a child again. I scoped her. She still have endoscopic disease activity. And I had a long discussion, and I thought we should think about changing treatment, because if you want to have a child, it's better if your endoscopy gets better. And I'm not going to discuss what options did I give it to her, but obviously she was very reluctant to change the treatment, and that's okay, but the discussion should be in that way, that we all both make decisions together. Thank you very much.
Thank you, Mohammed, so much. IBD is a very complex disease. The question is how to choose first-line treatment and how to choose second-line treatment. I think we could sit till tomorrow discussing these issues. Any questions for Dr. Alam, please? Go ahead. Can we have microphone?
Thank you. Thank you for this lecture. This lecture about choosing the medicine for IBD, we find it in every GI conference, because it's really confusing. So every conference you find this issue of what to choose, the medications, and so on. Also, the medicine with time lose its effect, most of them. That's why we always hear about new medications, new brands are coming in the pipeline. Now, to me, the